Good afternoon, everyone. iTech India welcomes all the participants for today's Regional Distance Learning Seminar session. Today's topic is nutritional care for HIV-infected children and counseling for children and adolescents living with HIV. We have with us today Dr. Rajeeb Dey sir. Dr. Rajeeb Dey sir is the Technical Specialist, Public Health with iTech India. We welcome you, sir, for today's session and request you to start the session.
Thank you, Swetaji. Good afternoon, everybody. So today's topic is nutritional care for HIV-infected children. And it is chapter number 3.6 of National Guideline for HIV Care and Treatment 2021. This topic was earlier taken by other speakers as a part of National Distance Learning Seminar Series. So today's discussion would be just a recapitulation of that one. Now, this nutrition Now, this topic would be discussed under this broad heading: assessment and nutritional management, counseling for children and adolescents, creating child-friendly ART center, child-centered counseling, and counseling the caregiver and child for lifelong ART, disclosure of HIV diagnosis to children, and other counseling message, and counseling for adolescents living with HIV, ALHIV. Now, coming to the nutrition care of HIV, nutrition in any normal children, this is characterized by rapid growth and development, and for which the energy requirement is more in growing child. But in case of HIV positive children, the need is more because of the infection, the energy requirement is more. And if we cannot supplement this increased energy requirement, then the patient will go into malnutrition. And with the malnutrition, there would be micronutrient deficiency, and the immunity will also get impaired. With the impaired immunity, the child will be more vulnerable to develop more of infections, which lead to further increase in energy requirement and leading to more of malnutrition. So this vicious cycle sets in a HIV positive children. So we need to take care of the nutrition of all the CLHIV attending our clinic. Now, to know the energy requirement, increased energy requirement, we need to assess the patient. So assessment is done starting with the history, then diet history. This is very, very important based on the socioeconomic status of the patient and also to the area where they belong. The food habits may be different. So we need to inquire about their food habits, what they usually take at home. And we also need to know the child's favorite dishes and which are the food that the child likes and which are the food the child doesn't like. And based on that, we can plan a balanced diet for the children. So it is very, very important to get the history, how they take, at what frequency, what they take, and how they prepare the food items, whether there is need for counseling them regarding the safe preparation of food and all. So all these are known only in taking a proper history of the children and his caregiver. And then we also need to assess the patient for any opportunistic infections. If there is any opportunistic infection, then definitely the energy requirement would be more. We'll see how much additional energy need to be given to them or calorie need to be given to a patient of PLHIV, a patient of HIV with or without opportunistic infection. Now, to assess growth, we should be using the WHO weight for age chart from birth to 5 years. And on the blue, it is for boys, and in the pink, it is for girls. So we can see there are 5 lines, and the median line is at 0. So anybody who is having a weight above the 0 line or above -2, then it is normal. But if the patient is below -2 standard deviation or the below -3 standard deviation, then it is a severe malnutrition. And we can assess it only when we are taking serial readings. At one time, we can simply be knowing whether the patient is having weight as per the average children of that age. But if you want to know the trend, then we'll have to record the serial number of weight at every visit. Then only if we plot those weight over this graph, then we'll be knowing whether the patient is gaining weight, losing weight, or is not improving, is a stationary one. Similarly, we also have length for age chart, where we'll be knowing whether the patient is growing taller as per his average age, or the patient is stunting, or there is height is not being gained by the patient. Similarly, we also have length or height, weight for length and height chart. So length we take for infant below 2 years of age, and above 2 years we take height. And here we'll be knowing whether the CLHIV is having adequate weight as per his length compared to the general population. So all these three combining will be able to know the proper growth and development of the proper growth of the children. Now, as we were discussing, that growing well means on the left hand side, the first one, the graph is going up, so it is basically growing well. If the curve gets flattened, there is a curve is plateaued, that the patient is not gaining weight, though it can be normal, but depending on the its relationship with the median line, that is at 0. If it is near to 0, that means it is still normal, but it is flattened. That means after some time, if we do not take proper care, the patient might start losing weight. And on the third figure on the right side, it is basically a losing weight. That is, the curve is going down. And immediately we need to assess the patient and intervene immediately to prevent malnutrition. Now, when we can assess, then we need to also classify malnutrition into different grade. And to classify, first of all, we should look for signs and symptoms of severe wasting, like edema present in both the feet, or the buttock is flat with loose hanging skin folds in the buttock or in the thigh medially, or even in the arm. Then if these are present, then we consider it to be severe malnutrition. And weight for height less than 3 J score is also considered as severe malnutrition. We can also go for MUAC assessment, that is mid upper arm circumference. If it is less than 115 millimeter in children, 6 months to 60 months, that is up to 5 years, then we call it a severe malnutrition. And in case of children, 5 to 9 years, if the mid upper arm circumference is less than 129 millimeter, then also it is a severe malnutrition. And if it is less than 160 millimeter in children 10 to 14 years of age, then it is also severe malnutrition. And in terms of BMI, it is taken for children for more than 5 years of age. If the BMI is less than 15, then we consider it to be severe, very severe underweight. And if it is 15 to 16, we call it a severely underweight. 16 to less than 18.5, we call it as underweight, and 18.5 to less than 25 is normal. Now, if the caretaker reports weight loss, or if the patient is having very low weight, that is weight for age is less than 3 J score, or underweight, that is weight for age is less than -2 J score, or confirmed weight loss of more than 5% since the last visit, or growth curve is flattening, then we call it as poor weight gain. And child is gaining weight means the weight for age is more than -2 standard deviation, and gaining weight appropriately, and we level them as growing appropriately. And we also need to identify the conditions which increases the calorie demand, chronic lung diseases, including tuberculosis, chronic opportunistic infections, or malignancies. And this should be known to the doctor, the nurses, and also to the counselor for proper nutritional assessment and counseling. Now, if a person is having HIV, then what additional percentage of calories needed for that person? And if the person is having, say, opportunistic infection, these are given here. So if we go through the top row, then first is age of the infant, that is if it is 6 to 11 months, then the daily energy need of HIV uninfected children, that is normal children is 690 calorie, while HIV infected and asymptomatic patient, there is 10% increase in the calorie requirement. Similarly, HIV infected with poor weight gain and other symptoms of, say, opportunistic infection, it is 20% additional energy is required. And if severely malnourished and along with the HIV, then the increase in energy requirement is 50 to 100%. So similarly, the same increase in energy requirement has been depicted in 12 to 23 months up to 10 to 14 years. Now, once we assess the patient, once we categorize, once we know what additional amount of calorie the patient needs, then we need to manage such a CLHIV. So as we are discussing visible wasting, bilateral edema, severely impaired growth, then definitely we are going to screen for opportunistic infection, anemia, drug side effect, treatment adherence, treatment failure, and of course, CIDs. This treatment failure and drug adherence becomes more important when the patient is already on ART, was doing well earlier, but now suddenly the weight is losing. Then we may suspect that there may be issues with treatment adherence, or the patient is actually failing on a particular ART regimen. And this IRIS is also important because many a times we may confuse IRIS with the opportunistic infection, so we need to exclude IRIS. Now, once we know the level of nutrition, poor nutrition of the patient, and the increased calorie requirement of the particular patient, then we need to provide them by, say, if the patient is asymptomatic and growing well, but HIV positive, then the additional energy requirement is 60 to 70 kilocalorie per day. And if there is poor weight gain, it is 120 to 150 kilocalorie per day in a child of 6 to 11 months of age. Now, how to use it? If we can add 2 teaspoons of edible oil or 1 teaspoon of sugar to porridge, or say any other food item that the patient is taking, which is available in their area, and as per the staple diet of the patient, we can add 2 teaspoonful of edible oil or 1 teaspoonful of sugar to make to provide an additional energy of 60 to 70 kilocalorie per day. Similarly, the same thing, if we add twice, then it will make 120 to 150 kilocalorie per day. Similarly, in severely malnourished, the patient will not be taking orally. Even if it is taking, he will be very, very sick. So for all the severely malnourished children, we need to admit the patient. So, and they will be taken care of in the indoor with the replacement therapeutic feeding. Now, similarly, for 12 to 23 months of age, we can see they're adding 2 teaspoons of edible oil or 2 teaspoons of sugar. Earlier, it was 1 teaspoon of sugar. Now it is 2 TSF of sugar to provide additional energy of 90 kilocalorie per day. Similarly, for providing 160 to 190 kilocalorie additional energy per day, we can add extra cup, that is 200 ml of full cream milk with 1 TSF of sugar and 2 big idlis, depending on whether the patient is taking roti or taking idli. If he's taking idli, then we can add 2 big size idlis, or 2 slices of bread with butter can be added to make it to provide the patient 160 to 190 kilocalorie of additional calorie. And severely, as we discussed earlier, it has to be done with therapeutic feeding in an indoor setting. Similarly, for 2 to 5 years, we are using whatever is available at home. For that, we need not have to buy costly items. Whatever is available at home and whatever is available in the area, from them, we need to prepare a balanced diet so that it can give proper nutrients, micro and macronutrients, along with adequate energy, adequate calorie. This calories can be added up with this edible oil, milk, butter, sugar, and even with the curd, extra rotis, vegetables, or parathas. Now, for providing 200 to 280 kilocalorie in a 2 to 5 years old CLHIV, we can increase it. We can provide it by increasing 2 puris with vegetables or 1 cup of porridge with 2 pieces of chickpea. Similarly, they have given the ways how we can increase the calorie for a 6 to 9 years old CLHIV requiring additional calorie. Similarly, in 10 to 14 years, and these are nicely detailed in our national guideline of 2021. So it is advisable that everybody should go through the guide Then along with this calorie, we also need to provide micronutrient supplements, say vitamin and vitamins. Vitamin A supplements has to be made every 6 months for children up to 5 years of age. For 6 to 12 months old CLHIV, it is 1 lakh international unit orally. And for 1 year to 5 years, it is 2 lakh international unit orally. For children beyond 5 years of age, vitamin A should be provided through daily micronutrient supplement. Whatever micronutrient supplement, multivitamins are available in the hospital, that can be given. Now, we need to deworm CLHIV with albendazole 400 milligrams single dose every 6 months for the first after the first year of life. And we also know that we need to continue potrimoxazole prophylaxis therapy to prevent occurrence of different opportunistic infection till 5 years of age. And in patients with recent history of diarrhea, we should provide 20 milligrams of zinc orally per day for 2 weeks. And along with this assessment and intervention in additional calorie, in the provision of additional calorie, along with the micronutrients and macronutrient supplement, we also need to encourage the CLHIV to go for regular exercise and activities, so that the patient feels better and there is overall development of the patient. And we should also encourage them to go for routine childhood immunization as per the national immunization schedule. So we need to counsel the caregiver and also the patient that there is increased need for additional food because the childhood is a growing period. Second, the patient is having a HIV infection with or without other opportunistic infections. And how we can modify our diets with the available foods item in this in that area, that also we need to counsel. And how to prepare the safe food and how to store the safe food along with the water safely, and how to use proper hygienic ways to prepare food. So these are again given in the national guideline. So first of all, washing hands is very important. Wash all your hands after going to toilet, changing the baby, or being in contact with animals. Wash or clean all surfaces and equipment. Protect kitchen areas and food from insects, pests, and other animals. Then separate raw meat, poultry, fish, and seafood from other foods. Use separate equipment and utensils such as knives and cutting boards for handling raw foods. Store food in covered containers to avoid contact between raw and cooked food. And cook food thoroughly, especially meat, poultry, egg, fish, and seafood. And we should bring foods like soup and stews to boiling point so that it kills the germs, whatever present. Then we need to reheat the cooked food thoroughly. So we need to counsel the caregiver how to prepare safe food and how to store them and how to reheat them and to provide to the babies. And we should also say that do not leave the cooked food at room temperature for more than 2 hours. If more than 2 hours is needed, then we need to store it in a refrigerator. Do not store food too long, even in a refrigerator. And do not thaw frozen food at room temperature. Then food for infants, young children, and other people with a low immune system should ideally be freshly prepared and not stored at all after cooking. So it is a very good advice, and wherever possible, we should follow that. Every time the child needs some food, we should freshly prepare the food and provide to the CLHIV. So feeding recommendation during the sickness and health. We all know that up to 6 months of age, breastfeeding as often as the child wants, day and night, at least 8 times in 24 hours. And we need not give any other foods or fluids during that initial 6 months. Similarly, from 6 months to 12 months and 12 months to 2 years also, how we gradually introduce the supplementary food. And after 2 years of age, whatever the family food is available at each meal, we should provide that to the children at least 3 times a day. And we also provide snacks such as with banana, biscuit, chiku, mango, papaya in between meals. Now, we need to remember to continue breastfeeding even if the child is sick. There are myths that if the patient is having diarrhea, then milk might produce loose motion, but we should need to counsel the caregiver that they should continue breastfeeding even if the patient is having diarrhea and other sickness. Then for 6 months to 12 months of age, uh, 3 times per day of breastfed plus snacks, or 5 times per day if not breastfed. Then keep the child in your lap and feed with your own hands. Wash your hand and child's hands with soap and water every time before feeding. And for 12 months old to up to 2 years, 5 times a day, food can be given if not breastfed. And here also we need to remember that the patients, the caregivers who sit by the side of the child and help him to finish the serving. And here also we need to wash our hands and the child's hands with soap and water every time before feeding. And for 2 years old, 2 years and older, ensure that the child finishes the servings at each time, at least 3 times a day, and teach your child wash hands with soap and water every time before feeding. Now, there are different myths that goes on in the society. Say, for example, in diarrhea, it is not good to take milk or bananas and all, because it is thought that it increases the diarrhea. But we need to counsel them. Then the patient needs nutrition, and for that, the milk and bananas can also be given, and doesn't increases the diarrhea. Then along with this, during diarrhea, we need to replace the lost fluid with breastfeeding, or replace with fermented milk products such as yogurt, or replace half the milk with nutrient-rich semi-solid fluid. And we need to add cereals to milk like rice, wheat, and for foods, follow feeding recommendations for the child's age group, child age. Now, once we assess the patient, categorize the patient, and intervene with the adequate nutritional supplement, nutritional intervention, we need to follow them up regularly. The child who is well and growing appropriately, then we need to follow them up at least 2 to 3 months. 2 to 3 months. And we should continue cotrimoxazole, micronutrients, and other supplements if necessary. And if the child is on ART, then every 3 months or 2 to 4 weeks. If 3 months, if the patient is gaining weight and no other problems are there, and we will follow them up 2 to 4 weeks, if not gaining weight adequately. The child who has chronically increased nutritional need but investigated and no other active problem.
So you'll have to share the screen again.
Uh,
It's visible, sir.
First visit.
Yes, sir.
Hello.
Yes, sir. You're audible, sir.
Am I okay? Okay. A child with poor weight gain. First visit is made within 1 to 2 weeks, and then and we need to tell every time the caregiver to return earlier if there are any problem like health issues. Is unwell and or showing signs of growth faltering, or has had recent diarrheal illness, then we need to follow them up every 2 to 4 weeks. May require more frequent visit depending on the clinical status, and we need to provide support. And when the child is malnourished with or without other sign and symptoms of disease progression, as for example, history of recent severe weight loss or recent diarrheal illness, then we need up weekly. And if fulfills criteria for management at home, then we need to follow them up. Otherwise, we need to admit the patient for proper investigation and intervention. When a child is severely malnourished with medical complications or no appetite, then the patient needs to be referred to the hospital for inpatient treatment. Now, once we have taken care of the malnutrition part, how do we counsel the children living with HIV? Child and caregivers need to be counseled for the different challenges faced with while counseling a CLHIV. Then we need to know the different child-friendly how to make child-friendly ART center, and how our counseling need to be child-centered, and how to counsel the caregiver along with children in all types of counseling, whether it is preparedness counseling, adherence counseling, or follow-up counseling. Counsel the PLHIV, but in case of CLHIV, we need to counsel the CLHIV along with their primary caregiver. Now, the different challenges that one face while counseling CLHIV are divided into three groups. There is caregiver-related challenges like frequent sickness or mortality in parents, because most of the CLHIV have their parents who themselves are PLHIV. So many of them might die, and then there is frequent change of caregiver. With the death or sickness of a primary caregiver, some other takes the role of a caregiver, and this also leads to change in attitude, beliefs, and habits of the caregiver. With the change of caregiver, definitely this beliefs, attitude, etc. changes, and these are quite challenging. And every time the primary caregiver changes, the counselor need to know what kind of value system the new caregiver has, and what is the beliefs and attitude towards HIV and its treatment. And then only we can provide them with good counseling so that their adherence become well, and they also retain in the treatment for a long time. Then child-related challenges are dependency on adults for treatment, because child themselves cannot take medicine in time, so they all need to depend on the caregiver. And poor attention span of the children makes it very difficult to impress upon them the do's and don'ts. So we need to engage with them quite frequently, and we need to repeat the messages that we like that we like that the child should remember. And the difficulty experienced by the child in communicating feeling and thoughts, and for that matter, many times the storytelling or drawing can be encouraged so that the patient, the CLHIV, can express his thoughts. Because of poor vocabulary, many a times they do not know how to communicate their feelings. And here, those alternative methods like drawing and storytelling, etc., becomes very useful. And poor physical growth of the child and delayed development of milestones. So his IQ level may also be less than the children of our age who are not having any HIV. And with the growing age, the child's understanding gets on changing, and we also need to change the way we counsel that particular children. So we need to readjust the counseling every time the patient comes to us. Now, home environment related challenges. These are sickness or economic constraint or discrimination and stigma that are prevailing in a particular society or the home. Now, how to address these challenges? We can address these challenges by supporting the child and caregiver through sensitive and caring counseling. Means we need to follow them. There should be eye contact, and we should be very, very sensitive to what the child is saying. We should not ignore that is a little child, and we should not listen to them. We should listen to children attentively, just like an adult, we listen to an adult. And we need to answer their all queries and curiosities and confusions, and we need to make them we can empower them by providing proper information. And our counseling should need to be tailored as per the child's age, developmental status, and ability to understand HIV disease and treatment, and his or her social circumstances. By identifying the primary caregiver and a backup secondary caregiver if the primary caregiver is not available. So this is very, very important while counseling CLHIV. That primary caregiver is there. In most of the cases, it may be the parents, but they themselves are likely to have a PLHIV, and they may die before the children. And in that case, a secondary primary caregiver need to be identified, or during his sickness, the secondary caregiver should be available with the children. Now, by sensitively addressing challenges of coping with adherence to lifelong treatment, issues of disclosure, confidentiality, stigma, and discrimination in their immediate environment, issues related to education, career, relationship, etc., need to be taken care of. Now, how to create a child-friendly ART center? So this child center, child-friendly ART center is to so that the child considers that it is not a hospital, rather it finds it to be a friendly environment, and it encourages the children to express them, and it can be provided by the provision of a separate room for counseling, and then small chairs can be arranged, drawing papers, crayons, and others art material should be provided. Storybooks, games, and toys for children can be kept there, and while displaying the painting done by other CLHIVs, and blackboard and chalk placed at the child's eye level. So all these are to encourage the child to express their feelings through different means, because many a times they fail to communicate in words. Now, how to go for child-centered counseling? Now, these basic things are need to be followed even while counseling a children. We should try to establish a proper rapport between the child and caregiver and the counselor. Now, here we need to follow that gather principle, that is to greet the patient. Even if it is a child, we need to greet the patient. Hello baby, how are you, like that, and then ask relevant questions and these questions need to be open-ended one, it should not be a closed one. And then we need to tell them with the right information to their all queries, and we also need to help them to reach a decision. And we need to explain different queries and concerns so that they can approach a decision. And we also need to tell them when to return back in cases of any health issues. Now, focusing on the child's need, the patient, this CLHIVs can be a restless one, but we need not be very judgmental about them. We always should ignore that, and we need to focus on the things that we need to tell the patient, and to address his queries and confusions. And our counseling messages should be tailored to child's physical and psychological development. And we also need to encourage the child to express himself fearlessly, and we also need to impress upon him that he can confide in us, and we will also maintain the confidentiality. And we also go for building the self-esteem of the patient, respect the child's identity and emotions, and we need to protect the best interest of the child, including the right to participate in decision-making, non-discrimination, confidentiality of information. And we always involve the child and the child's caregiver in all the decision-making. In fact, we provide them the information with which they can decide their own. Then rapport building, we need to greet the child, as we said, and introduce ourselves and why we are there and how we are going to assist him or her. Then we need to clarify all the fears and misconceptions about counseling, and setting the context, that is the child knows why and for what concern he has been referred for counseling, and assuring the child of confidentiality, neutral play and art activities to build a therapeutic relationship and a spirit of collaboration. So all these things ultimately give rise to a proper rapport. And while the different other counseling skill like reflective listening, then paraphrasing, all these hold goods, even if it is a child, we need to follow all those standard guidelines of counseling. Listening, as we were saying, then we should pay full attention to the child's verbal and non-verbal communication. And in a children, many a times it is more of non-verbal communication than verbal ones. And we need to interpret, and we need to ask them, and we can share the stories and difficulties experienced by the child. The child may say some pains and all, and we can correlate with the, yes, I also had it in my childhood, but it somehow went off and we did this thing. So your problem will also go. So thereby we ensure that the child understand that we are not only acknowledging what they are facing, we also realize what they are facing, and we are understanding them correctly. And it also proves that we are supportive of their concerns. Then recognizing and acknowledging emotion, validating children's difficult experiences and emotion. This assures children that you not only understand, but also emphasize with their predicament. This helps children feel supported and comforted. Any suggestion or advice provided by the counselor needs to be predicted on such understanding and acknowledgement of child's emotion. Acceptance and non-judgmental attitude. This is the backbone of all types of counseling. And here also we should not be very judgmental. We should not be critical, and we should not be blaming the child, whatever the behavior is. Providing the space for children to examine and analyze their actions. Such reflection services serves as the basis on which they can make decisions about their lives and actions. Ultimately, the child takes the decision for himself or herself. The counselor's role is to be an enabler in the child's decision-making process. So we should not be dictating them, do that or don't do that. We should be providing with all the necessary informations which are correct, and the child and the caregiver will decide of their own. Then questioning and paraphrasing. This paraphrasing is very, very important to make the CLHV understand that they have been listened and their concerns have been understood in a proper way. Now, counseling the caregiver and child for lifelong ART. As we know, there are 3 different types of counseling. One is preparedness counseling, adherence counseling, and follow-up counseling. These 3 stages are also there in case of CLHIV. And in preparedness counseling, it includes education regarding the preparation of the child and caregiver for lifelong therapy. We need to make the caregiver understand that this therapy is for the entire life and they should not miss. And it is crucial for good adherence and a successful treatment outcome. The adherence need to be very, very good. More than 95%, that we need to make the CLHIV and the caregiver understand it very nicely. And this message, to absorb this message, there are many sessions may be required, may not be in one session. It is possible in all the cases. In some cases, we may have to go for 2-3 sessions. And it is very necessary to evaluate the child's social environment, including identifying a clearly defined caregiver who can understand the prognosis of HIV and the implications of ART and ART and its side effects. So messages for children are like those for adults. As we were discussing, we should not be considering that it is a child, so we may bypass or we may ignore it. We should not ignore. We should follow all the stages of counseling as we do in the case of adult. Now, to counsel the caregiver, we need to identify the primary caregiver. Usually, it is a parent, one or both the parent, but maybe other family members, or at times a caretaker from an orphanage. If the patient is orphan, then a caretaker from the orphanage can be identified as a primary caregiver. Advantages and limitations of ART need to be told to the caregiver that with ART, almost a normal life is possible. And also we need to say about the side effects of ART and importance of adherence. The ART works only when the adherence is optimal, and knowledge of drug toxicity and storage of drugs must be explained to the caregiver. And we need to help them with help them to deal with the personal guilt, worry, as well as acknowledge that the emotional needs of the parents cannot be a reason to ignore or subsume the needs and rights of the children. Many times, the caregiver, if they are parents, they themselves might be suffering from depression and all, and they may be indifferent to the treatment of the children in such a case of their child. In such a case, we may arrange for one more other people as his primary caregiver. And the family needs to understand and accept the illness and its implication in the family before treatment can be initiated. This preparedness counseling and identifying the primary caregiver and caregiver counseling, these are pre-requirement for the initiation of ART. And we need to sensitize the caregiver about the disclosure of HIV status and disease information to the affected child. Disclosure needs to be age-appropriate one as per the guideline and according to his or her level of understanding. Now, the 5 A's in the preparedness counseling are to assist the child and caregivers about the knowledge of HIV, right understanding of HIV, and how it is treated, and potential barriers to adherence and treatment and their social support systems. So based on their problems of say, social support system or adherence issues or socioeconomic problems, we need to assess all those things as the baseline. Then we need to assist the child and the caregiver to developing a plan of good adherence and how they are going to uh, 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 take care of those barriers that we need to plan in coordination with the child and its caregiver. And we need to advise the patient and the caregiver how ART works and the need for lifelong treatment with good adherence, and which also requires regular follow-up visit. And we need to arrange medical investigations and appropriate referrals. And ultimately, with this the child and caregiver both should understand and accept and agree to the formulated treatment plan and 100% adherence. And in the next visit, we are going to reassess this, whether they are successful or not. And based on that, again, we may have to develop or modify the plans. So what, when, how, and who about ART medicines are to be told to the caregiver clearly. That is what means what medicines will be given, whether it is a pill or a syrup, color, shape, etc. And what dose the syrup or tablets is to be given. And if the patient vomits, if the vomiting is within 30 minutes of ingestion, then it can be repeated. And if the vomiting after, we need not repeat it. Then when that medicine should be given and at how frequently it has to be given, and ensure that this timing is linked with the routine of the child. That is, if it is once a day, maybe we will link it with before going to sleep. Or if it is twice daily, then before breakfast or after breakfast or before dinner or after dinner. That is how we are going to link them with the activities, routine activities of the child. And we also need to provide details on how medicines will be given or taken. That is, how frequently if it is required to be halved, if it is a scored tablet, and how the medicines to be given. And we should also make for some reminders. It is very, very difficult to keep on taking medicine every day in right time. So we also need to arrange for some reminders in around 10 to 20 minutes before the fixed time for. Then identify who, that is, who will administer the medicine. If it is the mother or the father or some elder people who will provide the medicine, that need to be clearly defined. And it is essential to identify the primary caregiver and a backup secondary caregiver in case the primary caregiver becomes sick or dies. Now, counseling caregiver about the side effects of ARV drugs and home-based care. We need to prepare the counselor for the possibility of minor side effects of ARV like nausea, headache, abdominal discomfort, and we need to explain them that these are usually self-limiting and home-based care can be given. And these are detailed in other sessions of RDLS. Now, we need to provide the IC material if available on the side effects, and counsel that mild side effects will recede over time or respond to change in diet or method, and timing of medications may also elevate the problem. Then adherence counseling. It is essential to achieve adherence counseling is very, very important to achieve vital separation. And as we saw that many a times CLHIV tend to vomit. So in such cases, the history taking, how the patient swallows medicine and how often he vomits, all these things are very, very important to accurately assess the adherence. And it is essential to educate both the CLHIV and the caregiver about adherence to ART at the time of ART initiation and during the subsequent visit. And we need to regularly go for pill counts at every visit. And we also need to look for adherence to other co-medications, say, for example, CPT or PPT, we also need to see for the adherence of other medicines, co-prescribed medicines. Now, it is essential to involve the child in adherence assessment so that he or she also realizes that adherence is very, very important. Use interactive methods such as field charts and storytelling with children. And we may have to suggest various ART reminder tools, including calendars, alarms, SMS, reminders, refill boxes, and field charts. All these are the tools for increasing the adherence so that the patient understands the importance of adherence and actually take the medicine as per prescription. Now, common barriers of adherence in CLHIV, child-related factor are the dependency on adults, likes and dislikes of medicines, bitter taste, emotional issues, using medicine to manipulate adults. Many a times the patient, because he understands it is very, very important to take medicine, so many a times they tend to manipulate adults by not taking the medicine. Or basically they tend to blackmail their adults by refusing to take the medicine. And other infections and other medications make it difficult for the patient to adhere. And infection also reduces appetite and appetite. So all these things can cause problems of adherence from the child side. And from caregiver related factors are knowledge and understanding of the treatment and its application may not be adequate. So they may not provide medicine at time. And misconceptions regarding treatment. Some people say this small child is taking the same size of tablet as that of an adult, so let me divide it. So all these things need to be taken care of before saying that the patient is having adequate adherence. And what other health benefits, whether they believe that taking medicine for a long time will harm the patient. Those beliefs, if they are, then we need to rectify them. Then daily routine, nature and timing of job. The patient job timing and children's school timings also need to be taken care of, which can at times be a barrier to adherence. And in case of repeated changes in caregiver, each and every time we need to assess the new caregiver and counsel them accordingly. And we also need to know the type of relationship the child has with the caregiver. And adherence fatigue in children. This usually seen after 2 years of good adherence. It is sign in the form of marked change in the confidence level and attitude towards the treatment, an expression of feeling bad for being the only one to take medicine among his peers. That is the peer pressure. No other friends are taking, so why shall I take? And they are feeling very confident and fit because of, say, adolescence. So many a times they stop taking medicine after about 2 years of good adherence. The caregiver can also face adherence fatigue and may feel tired of administering or supervising the medication. So at every visit, we need to care about these possibilities and counsel them adequately accordingly. Then disclosure of HIV diagnosis to children living with HIV. There are different types of disclosure, like initiating disclosure for age 4 years to 6 years. When the child is curious about many issues and concepts of illness and wellness, this is the time to go for partial disclosure. At the age of 7 to 11 years, when the child is aware that he or she or the parent has a chronic illness and is taking daily medications for it. And full disclosure can be done when the patient achieves the age of 12 years or above, when the patient understands full disclosure, when the patient understand about the nature of the disease and all, then full disclosure of illness to be done. So the examples are 3 to 6 years, you are not well. If you want to play, you should be well. And for that, you need to take medicine. For 6 to 9 years, you have some germs inside your body. The germ is making you fall sick often. To kill that germ, you need to take medicine every day. The germ will become strong if you don't take medicine. And from 9 to 12 years, there is a germ in your body. It reduces your body's ability to fight other infections. We cannot remove it from your body, but we can control it so that you stay healthy. For that, you must take medicine regularly. So these are the messages how we gradually go for disclosure of diagnosis to growing CLHIV. Now, we need to understand the caregiver's fear and concern. It is important that the level of knowledge of the caregiver about the illness before planning HIV disclosure, the service provider should know it quite well. And we also need to provide the basic information about HIV. How does one get HIV? What are the treatment options and how one can manage the symptoms, the importance of adherence to treatment. They will then have a chance to ask questions and we need to clarify all their doubts and share their concern. Now, what are the needs need for disclosure? That also need to be discussed thoroughly. It is important to explain that the consequence can be of what would be the consequence of not letting the child know that he is infected with HIV. Children, even when not provided the information directly, can sense stressful situations. They may sometimes directly ask, sometimes they may not ask, but they will try to process information and assign meaning to what they sense, see, or hear about the situation around them. The unprocessed thought, doubts, and questions will only make them anxious and fearful. Similarly, given the fact that there is a lot of stigma in case the disclosure is not made by the parents, but by a peer, neighbor, or a stranger in an abrupt and sudden manner, it may be very much shocking and hard for the child to process. So there should be a plan of disclosure and accordingly we should proceed. Therefore, it is best to prepare the child and the provider authentic information to avoid unnecessary traumatization with the diagnosis of HIV. Caregivers' fear and concern to be addressed, and the parents may still have concerns and fear about disclosure. It is a common belief that the child will not understand if told as they are not mature enough, or it will scare the child if they are told about the illness. It will cause worry and anxiety in them. Therefore, using diversionary method or completely avoiding the subject feels like an easier option. Parents should be prepared to give limited age appropriate information to the child without going into the possible implications at the time of disclosure. So we need to make them understand these are the usual concern of all the parents, but it is not, it may become counterproductive if we do not disclose the diagnosis to the child gradually as per his age. How, when, and by whom disclosure would be made? It can be made by the counselor or the parents. It depends on the circumstances and the comfort of the child. In case the parents carry out the disclosure process, the counselor can prepare them with the right script to make disclosure, the way we showed some examples in previous slides. And the counselor remains in the background and helps manage any difficulties, whether it is emotional or behavioral, that may arise after the disclosure of the diagnosis to the children. Now, other counseling message: nutrition and safe food handling that we already discussed earlier. Then immunization advisory. We should encourage and ensure timely immunization of CLHIV. In asymptomatic CLHIV, with CD4 count of above 15% can be safely immunized even with the live vaccines. And the SMO or MO should assess the child for the safety of immunization with live vaccines. There are certain exceptions and to this general rule. And these are all been is there in the technical guideline of NACO 2021, and one should go through it so that we can advise the patient adequately regarding immunization. Now, planning for the future of the CLHIV. When caregivers are parents who are on ART themselves, it is important to alert them to the need to plan for the future of the child in case they die prematurely. Now, it is also important to enable the parent to identify who will be the legal guardian after them and the caregiver after them in such a eventuality. Now, ALHIV, this is a very difficult phase of life, particularly in the field of ALHIV. There are two different types of adolescent ALHIV. One is vertically infected from the parents and one is horizontally infected adolescents. Now, vertically we know they are likely to be in advanced HIV stage with more of opportunistic infection, and there is more of growth and developmental delays and higher mortality rate. Disclosure of HIV status is partial or none, and likely to have experienced multiple HIV-related losses of parents, relatives, etc. Then experience stigma early in life, that is in school or at home or in healthcare. But horizontally infected adolescents, they have earliest stages in the HIV. OIs are less likely. Effect on growth and development are less, and they have lower mortality. if accessing HIV services, likely to know status, and unlike the vertically infected one, likely to lack familial, social, and clinical support system, because they might be the only person HIV positive in their family. So the familial support, social, and clinical support may be less, and experience of stigma later, exacerbated related to drug use and sexuality, like the vertically infected adolescent who face the stigma early in life. Now, challenges of adolescence are new cognitive capacity, evolving decisional capacity, struggle for independence, question authorities, need to identify with peers, preoccupation with self-image, risk-taking behavior, then changing that hormonal rush, and all these things give rise to difficulties in adolescence, which are unique in this group. Now, challenges of HIV infections are HIV-associated stigma and discrimination, chronic disease requiring daily medication, long-term morbidity related to both HIV itself and its treatment, then associated adverse socioeconomic conditions. They may experience poor physical growth, delayed puberty, and impaired bone health in if ART is delayed. In case of vertically infected PLHIV, may have delayed development and cognitive and memory impairment, and may not perform well in school, due to which dropping out of school is very common. Many long-term HIV-related morbidities are there. Prevalence of psychiatric and behavioral problem is also higher in them, and they may not know their own HIV status and that of their parents. They are required to take daily medication for ART, the need for which they may begin to question, and challenges related to long-term duration of ART, including faltering adherence, treatment failure, treatment-related side effect, and likely complex ART regimen are also commonly seen. HIV-associated stigma and discrimination is also felt very early in life for those vertically infected adolescent. Now, horizontally infected adolescent, they tend to live in the fringes of society, hiding their sexuality, occupation, or gender from their families and peers. And there is difficulty which due to criminalization of drug use, sex work, consensual sex between males, and fear of arrest and abuse if their behavior is discovered. And they face challenges in disclosing their status to caregiver or family, and engagement and retention in HIV is also challenging. Delayed detection of HIV due to low index of suspicion in largely asymptomatic adolescent, because HIV progresses quite slowly in adolescent, and lack of adequate youth-friendly voluntary testing facilities and requirement of parental consent for HIV testing also hinders a proper diagnosis. Now, loss to follow-up is very high in this group of horizontally infected adolescent. And the common challenges faced by both vertically and horizontally infected adolescent are adverse family and social environment, poor support, difficulty in accepting and learning to cope with their diagnosis, and impact on various aspects of their life, increased mental stress, and risk of recurring deviant and aggressive behavior, higher chances of hindered education and career-related challenges, difficulty in coping with relationship following protected sexual practices, and greater risk of unwanted pregnancy. Now, counseling ALHIV, then we need to understand, make them understand HIV, lifelong ART, need of treatment adherence. Just like in CLHIV, we need to go for all those points like treatment adherence, disclosure, healthy living, nutrition, growing up and changing behavior, sex and relationship, pregnancy prevention, life skills like communication skill, handling stigma and discrimination adequately, decision making and planning for future. All these things need to be counseled in case one ALHIV. And there are certain do's and don'ts of communicating in adolescent. We need to know that we need to be truthful about what we know and what we are going to tell. And we need to be professionally and technically competent. The words used and concept they can understand need to be said. Use pictures and flip charts to explain. Treat them with respect in terms of how you speak and act. Give all the information, choices, and help them decide what to do. Treat all adolescents equally. Be understanding and supportive, even if you do not approve their behavior. Accept that they may choose to show their individuality in dress or languages. And the different A's, 5 A's: assess, advise, agree, and assist and arrange. so that the patient can deal with their worries and all. And we need to advise a treatment plan how uh, uh, and we need to correct any inaccurate knowledge and fill gaps in the adolescent understanding of his or her condition. On being young and living with HIV, how the relationship should be, and sexual intercourse, how it need to be protected one, and alcohol and drug use should be discouraged, and on sexual activity, how to use condom, contraception, etc. And discuss couple counseling and the benefits of disclosing HIV status to chosen people, on peer support from other ALHIV, and on adherence, we need to advise them. And we also need to advise if we develop a treatment plan. So option available to the adolescent: risk reduction, positive prevention, prophylaxis, and treatment. On the simplest regimen possible, we need to put the patient on ART and evaluate the patient confidence and readiness to adopt and adhere to the treatment. Take the adolescent developmental phase with the Tanner scale, particularly sexual development, into consideration while prescribing ART. And then we agree that after explaining all those things, the patient need to agree with to whom they choose to disclose, and how and when they wish to disclose their status, on the that the adolescent and others will play in their care and treatment, and on the treatment plan that has been developed, on goals that reflect the adolescent priorities, and the patient need to agree. And we also need to assist with a written or pictorial summary of the plan and provide referrals to adolescent in case of health issues. And we need to arrange for the adolescent will do in the time between visit to you, if he develops any side effects and all, when to whom to contact and how to contact. All these things need to be arranged before and while counseling the patient. Now, disclosure in LHV is also an ongoing process. It has a strong impact on the adherence and clinical outcome. Disclosure encourages the adolescent to take more responsibility and participate in their own care. It also improves retention in care. Adolescent need ongoing support for disclosure of their own status and disclosure of parental status. It is important to ensure that the adolescent is ready for the process of disclosure. Disclosure process should be tailored to meet the developmental need and understanding of the adolescent according to age. And we need to manage the barriers to disclosure, and staff should be accessible and open to answer their queries. Many times they can have some questions, and we need to be very much sensitive to their questions and queries, and we need to answer them as truthfully as possible. And that's it. Now, this is the next RDLS on 30th June. So today's topic is over. Now it's over to Swetaji.
Thank you so much, sir, for facilitating this session. Any questions from the participants? Please feel free to unmute your mic, or you can also type your questions in the chat box. Please block one more date for the RDLS session. That's going to be the last RDLS session of the National Guidelines for HIV Care and Treatment. The session is planned on Friday, that's 30th of June from 2 to 3 p.m. And the topic is palliative care for children and adults. So I don't think there are any questions. Can I quickly run the feedback poll?
Yes, please.
The feedback poll is now visible on your screen, requesting all the participants to please answer all the 4 questions. Requesting all the participants to please attempt all the 4 questions. Thank you, sir, for facilitating this session, and thank you to all the participants for joining in to this session and patiently listening.
Thank you. Thank you. Good day.
Good day, sir. Good day to everyone. We'll end the session now.